Good evening, everyone. I'm Bobbi Daniels, Associate Vice President for Clinical Affairs here at the University of Minnesota. Welcome to this year's first session of the Mini Medical School, Health and Wellness During a Pandemic. We're very excited to have you here today, and we look forward to guiding you through our first topic in the series, Pandemics Through the Ages. We have set this up as a moderated discussion with questions and answers to follow. Please note that this session is being recorded and will be uploaded tomorrow on the Office of Academic Clinical Affairs YouTube channel. Today, we have the pleasure of hosting a panel that will be discussing a history of pandemics, lessons that we've learned, and what the latest phase in the COVID-19 pandemic looks like. If you have questions for the panelists or for me, please type it in the Q&A box and I'll pose it to the panelists. And now, to introduce our panelists, I'll first bring in Jennifer Gunn. Dr. Gunn is a History of Medicine endowed professor and served for 8 years as the director of the program in the History of Medicine. Dr. Gunn is a historian of 19th and 20th century medicine, interested in the historical intersections of health, medicine, biology, social sciences, institutions, and public policy. Dr. Gunn, can you talk about the COVID-19 pandemic through the eyes of a historian and the lessons that we can learn from the 1918 pandemic?
Thank you so much, Dr. Daniels. Yes, but as a historian, I have to have my visual aids, and I want to show you a few pictures as we go along. And before I start, I just want to acknowledge that wherever we're joining from tonight, we are all located on the traditional, ancestral, and contemporary lands of Indigenous people. The University of Minnesota's Twin Cities campus resides on Dakota land that was ceded in the treaties of 1837 and 1851. So we acknowledge that this place has a complex and layered history, and a land acknowledgement is one of the ways in which we work to educate the campus and community about this land and our relationships with it and with each other, and to recognize, support, and advocate for American Indian nations and peoples. So it's appropriate to talk about influenza. And I'm always curious about why we particularly look to 1918 for historical examples when we've had other flu pandemics across the 20th century. And I think one of the reasons is that it was so clear at the time that it was a global pandemic, and it was set against the very dramatic background of the First Worldwide War and the accompanying movement of troops across the globe. It had such massive morbidity and mortality. There was a 2.5% fatality rate, which was much greater than the 0.1% mortality in previously recognized influenza epidemics. It's estimated that 1/4 of all Americans were infected, and 675,000 died in the US at a time when our total national population was only about 128 million. And it was also unusual in terms of who died. Younger people between the ages of 20 and 40, roughly, in the prime of life, as opposed to infants and the elderly, who are usually the most vulnerable, as they have been, or at least the elderly, during COVID-19. We've seen pictures like this of emergency wards set up in armories and gymnasiums, and pictures of people wearing masks. Oops, sorry. But I think that 1918 is so appealing as a comparison because community and governmental responses to the pandemic relied first and foremost on preventing the disease using the tools of public health. And those measures, isolation, quarantine, prohibiting public gatherings, mask wearing, and hand washing, are remarkably similar to those we have today, though the sophistication of today's epidemiological tools and the state of medical science in terms of testing, vaccine development, and treatments are actually very different. So there are a couple of things to remember about the historical context of 1918 that also emphasizes the differences between the present. In 1918, medical science couldn't identify viruses. They were too small for ordinary microscopes to detect, and therefore no vaccine could be made, though people did try, and vaccination was recognized as a key public health technique for diseases like smallpox. There were no antibiotics, so treatment depended primarily on good nursing care, and mechanical ventilation was rare and not in common use in hospitals. If you look in the second column down towards the bottom, you'll see a small article amidst the war coverage about the 1918 influenza. And I think there are a couple of examples from Minnesota that might help us think about some of the comparisons and lessons. So in theory, in 1918, Minnesota was ideally positioned for a statewide, highly coordinated response to the flu pandemic. The Commission of Public Safety, a World War I era agency that had been set up with emergency powers that superseded those of the state health department and even the legislature, had been in place for more than a year before influenza appeared. Governor Walz might be jealous. While the Commission of Public Safety did issue an ordinance in October 1918 to ban public gatherings and essentially quarantine towns, the commission may actually have ended up hampering rapid responses to influenza by leaving enforcement up to the municipalities and adding another layer of approvals and communications that was required. And it's interesting how inconsistent regulations literally drove people and the virus across the state. For example, people in Virginia, Minnesota, where public gatherings were prohibited, drove over to Eveleth, where the pool halls and so-called soft drink parlors were still open. The University of Minnesota postponed opening classes for regular students, but not for the Student Army Training Corps. And if you analyze, people have analyzed the 1918 data. And one of the things that they've discovered is that the cities in North America, which acted early and consistently over a long period of time to do three, what we call non-pharmaceutical interventions, to ban public gatherings, close schools, and implement isolation and quarantine measures. Those cities had a single flatter mortality curve and lower death rates. The famous waves of 1918 to 1919 were not as pronounced in those places. Well, Minneapolis is an interesting case because within 10 days of detecting the first influenza case, it closed schools and made flu a reportable disease so that the sick could be isolated. Theaters and churches were closed. The city sent inspectors with yardsticks into bars to determine that the customers standing at the bar were adequately socially distanced. Streetcars were mandated to keep their windows open, and people were not allowed to use building elevators below the 6th floor. Obviously, there were some serious contradictions and other inconsistencies. The armistice in November 1918, right at the height of a wave, looks like a probable super spreader event from this picture. And schools were too quickly reopened and then forced to close again. But at the end of the pandemic, Minneapolis had an excess death rate that was 55% lower than that of St. Paul. And in St. Paul, the health commissioner and business leaders had slowed government intervention. There were also longstanding turf wars between the state health department, the Red Cross, private health agencies, and the US military, which contributed to a poor cooperative response to the flu pandemic. This was exacerbated by another natural disaster, the fires of 1918 in northern Minnesota. So if you throw in the unwillingness or the inability of the US Surgeon General, the Army, and the Minnesota State Board of Health to mandate protective measures, restrict mobility, and facilitate the distribution of the short supply of medical personnel, you see that the situation was further complicated. This is an amazing chart of the organization of a civilian citizens influenza community to provide resources to neighborhoods in St. Paul. And local community organizations played a significant role in caring for the sick and producing needed supplies in 1918. You can see flattening the curve enabled those still standing in rural areas and small towns to organize meals and basic home care for their neighbors who were bedridden with influenza. Think about how critical that was when 25 to 40% of a community's population got the disease at roughly the same time. Local Red Cross chapters turned from rolling bandages for the military to making flu masks and pneumonia jackets. So this was a level of preparedness specific to the wartime occurrence of the 1918 flu. And while there was a debate then about the efficacy of masks and certainly about mask mandates in cities like San Francisco, communities applied pragmatic measures from experience to try to make a contribution and build morale. Even with today's commercially produced resources and PPE, it's still an issue of having them when and where you need them. So historical examples from 1918 reveal that containment measures could be imposed for compelling epidemiological reasons, but it was political, social, and economic priorities that also shaped their configuration and implementation, shades of today. Lack of consensus and reliance primarily on voluntary measures could be deadly. And as we're witnessing in the current pandemic, the tensions, political, economic, scientific, can undermine effective coordinated response to a global pandemic and might even contribute to the spread of the disease and the mutation of the pathogen. So today, as in 1918, we still have a lot to learn about these disrupting viruses, where they come from, why certain ones are more virulent. But officials and ordinary citizens communicated particular messages in 1918 to accomplish specific aims, whether it be blaming particular social groups for the failure of those containment measures, to promote the perception that officials are actively doing something to protect the public health and to avert catastrophic mortality, or to win hearts and minds, to educate the public about the merits of complying with public health measures. All of these depend, along with on the public's active participation and in their faith in the fairness and efficacy of prevention and treatment. So when historians, I think, look back on the period of acute pandemic COVID-19, I suspect that the lack of coordinated, equitable, and consistent participatory response within the US and across the globe will get the most scrutiny in the impact of this pandemic. Thank you. I don't know if that answered your question, Dr. Daniels, but I hope it's a start.
Well, thank you, Dr. Gunn. That was a fascinating parallel to the current times. Next up, we have Tim Schacker. Dr. Schacker is the Vice Dean for Research at the University of Minnesota Medical School. He's a professor of medicine and infectious diseases and is well known worldwide for his research in viral infectious disease. And he's been a major player and a contributor to the medical school's lauded team effort in response to SARS-CoV-2. Dr. Schacker, we're hearing a lot about booster shots. Why do we need them? And Will we continue to need them going forward every year like the flu shot? Can you share more about emerging protective measures against COVID and what we can do about predicting the next wave?
Yeah, thank you. So it's a pleasure to be here tonight. So in order to really understand this issue around vaccines, and I really understand that this is a complicated issue that has a lot of questions and people have a lot of questions about it, I'd like to just take you through a little bit of basic vaccineology, if you will. Next slide, please. I have no conflicts of interest with this talk. Next slide. But I want to frame this in a context that's really important. The normal, and we'll answer some of the questions about why there's so much confusion. The normal time that it takes to get a vaccine designed, tested, and approved is about 10 years. And we learn an enormous amount about that vaccine in those 10 years. We learn what dose is appropriate. We learn how many doses are appropriate. We learn what the level of protection that you might get from that vaccine is. Here in 200, and because of the pandemic, in 269 days, we went from a published sequence on the web of the virus to greater than 90,000 people on phase 3 clinical trials. And that's a tremendous achievement, and really one that we need to step back and go, that's an achievement. But because we fast-tracked this the way that we did, there's some of these questions that we have out there that we just don't have the answer to yet. Next slide, please. So I want to just walk you through a little bit about this process. This is a cartoon depiction of SARS-CoV-2, which is the virus that causes COVID-19. And we understand a lot because we've got the sequence of this virus. We understand a lot about its construction. And in fact, Fang Li, a member of our veterinary school faculty, was one of the first to actually establish what the structure of the spike protein is, which is the part of the virus that we're most interested in. And the reason that we're very interested in spike protein as the target for a vaccine, next slide, is because that is the protein on the virus that is used to attach to your cells. It attaches through a receptor called the ACE2 receptor. It's found on a lot of different cells in your body, but primarily on cells in your lungs, and which is one of the reasons why this causes pneumonia. And so what happens is that this spike protein attaches to the ACE2 receptor, allows the virus to get into your cells and causes the pathology and the damage that we've all come to know, sadly, over the last 2 years. Now, the spike protein is really the target that we want for our vaccines. So if we can find a way for our immune system to recognize the spike protein and then make antibodies against it, then we've got a way to prevent you from getting seriously ill should you be exposed to SARS-CoV-2. Next slide, please. There are 4 vaccines that you probably have heard about. The first 2 are the so-called RNA vaccines. So what the vaccine developers have done is they've taken the template of the virus that your body looks at that template and says, oh, I can make a protein. I can make the spike protein from that template that's in that formulation. So that RNA template is surrounded by some lipids, some fat, and that's what the vaccine is. And that's injected, and it is incorporated into muscle cells at the site of injection, and your body literally makes spike protein at a level that your immune system comes along and says, we're going to make antibodies against that. And it turns out that these RNA vaccines have been experimented with and used for more than 2 decades. This is the first time that they've been used clinically in humans. The other 2 vaccines are really more traditional vaccines that rely on a viral vector to express these proteins, and your body makes the antibodies to those proteins. And the really remarkable thing about at least the RNA vaccines is that we're seeing an efficacy that's pretty unusual in vaccines. We're seeing 95% of people protected from serious illness or hospitalization. And that is an achievement that is really remarkable. I think many of us early on in the pandemic, when we knew that these vaccines were under study and trial, 70% would have been a huge win. but when we were able to get to 95%, that was really just spectacular. So that's the reason why we're interested in the spike protein. That's how these vaccines are formulated and made and what they do. Next slide, please. But really what we're interested in is what's the antibody response? How does your body make antibodies against the spike protein in this case? And what does that mean? So what you're looking at here is a graph that looks at the amount of antibodies made. And you'll see that there's 3 different columns. The first column on the left is before you get the vaccine. The column in the middle is after your first dose. And the column on the right is after the second dose. And these are RNA vaccines. And there are 2 colors. There's green and lavender. Green are people who have never had SARS-CoV-2 infection. Lavender are people who had the infection prior to the vaccination. So there's several points to unpack in this slide. The first is none of us who have never seen the virus before and are not vaccinated, we don't have antibodies against SARS-CoV-2. After the first dose, you see a significant increase in the number of antibodies. After the second dose, you see an even greater increase. For those of us that had COVID, when you're tested, you will have evidence of some antibodies. But when you get that first dose of vaccine, that antibody response is boosted even further. But not much after the second dose. So the point that we're making here is 2 things. One, you want to know that you're getting a good response to the vaccine, and you want to know what the magnitude of that response is. And these are the kinds of studies that we do to answer that question. The second thing is that, yes, it is true that if you've been infected in the past, you will have some level of antibodies. It's going to be variable from person to person. But if you do get the vaccine, you will have a significant increase in the protective effect of those antibodies. So that's just a really quick walk through what the virus is, the target that we have in spike protein, how these vaccines were constructed, and the kind of responses that we're looking for when you get the vaccine. The real question, and I suspect we're going to get several of these questions, is, so why are we recommending booster shots now? So, why are we doing the mix and match approach now? And the reality is, as I said before, we did this in record time. And this is the analogy that I've used all through the pandemic is this is a little bit like flying the airplane while you're building it. So I wouldn't actually call this a booster shot. I would call this the third dose. We don't, and it is true that the data supporting that are mixed, and I suspect Dr. Osterholm can speak to that. But the reality is that the clinical data that we have out there suggests that, that some degree of waning immunity occurs in some people, and that suggests that 2 doses aren't enough. The third dose is important. Next slide, please. And I want to make the point that it isn't like every single vaccine is one and done. And remember, these took many years. These studies took many years. But all of us probably are vaccinating our kids against HPV. That's either 2 or 3 doses, depending on the age that you start the vaccine series. The older you are, the more doses it will take. Influenza, we all get a dose. Well, we should all get vaccinated every year, and I hope you do. Hepatitis B virus, that's 3 doses. Yellow fever, very, very potent vaccine. That only takes 1 dose. Shingrix to prevent shingles from varicella zoster virus, the chickenpox virus, that takes 2 doses. So the point that I'm making is, why do we need this booster? Part of it is because of the speed at which we rolled this out to try and protect our community and our people from the serious effects of SARS-CoV-2. In the few minutes that I have left, I want to talk about one other project that we are doing here at the university that has to do with surveillance. So how can we track the spread of this virus through our community, and what does that mean? And we're pretty excited about this project. Next slide, please. And what we've done, and actually it's the 2 gentlemen that you see on your screen who are faculty members in Duluth, Glenn Simmons on the left, and Rich Melvin on the right. What they've done at the beginning of the pandemic in April of 2020, they went out and they created a network of wastewater treatment plants across the state that we could collect wastewater from and do testing. It's the same test. When we swab your nose and we look for evidence of COVID, we do that same test on the wastewater to see if there's SARS-CoV-2 RNA in that sample. So we're testing wastewater to see if we can find out what's happening in our communities. This is something that's been done in different places, literally around the world. I think we're unique in that we have sampled literally all across the state in a way that we can sample 63% of the population of the state of Minnesota in a truly unbiased fashion. You know, when you get tested for a reason. Levels of SARS-CoV-2 in wastewater, that's not a biased sample. That's everybody's contributing. Next slide, please. So these are the sites, just to give you the impression, just to give you the idea that they're all around the state. Next slide, please. And this is the kind of data we're getting. We look for two targets. We look for two parts of the virus. One is depicted in red and one is depicted in blue. And what we've done is created an index that allows us to normalize this data to a virus that's found in every wastewater sample. It's called pepper virus. And you can see how well this tracks the various outbreaks that we've had, or the surges that we've had over the last several months. And in fact, this is data that was from just a couple of weeks ago. And you can see that the increase in this particular town in northern Minnesota, you can see that there's an enormous amount of virus circulating in that community. Now, these folks are primarily vaccinated, I presume. That's going to make a huge difference. But still, we have this ability to do this surveillance. Next slide, please. And what we found is that by measuring this, we can predict, with some caveats, we can predict within 7 to 10 days when a surge is going to happen in a particular community. Now, that's not very useful or helpful today, but I think in future outbreaks, in future infectious disease outbreaks, if we can apply this technology, we will have an early warning tool that will be very important. Next slide, please. So in summary, previous infection may confer protection, but vaccination boosts that immunity. Very important. Clinical data at this point support a third dose of vaccine, and it is possible that periodic boosters will be needed as new variants emerge. It's likely, in fact. Wastewater surveillance appears to be an effective early warning system. So next slide, please. Next slide. So with that, I'll close and thank you and turn it back over to Dr. Daniels.
You're on mute, Bobbi.
Well, I'm sorry about that.
No problem.
Thank you, Tim. That was very, very good to hear about, and certainly your work and those of your colleagues is to be congratulated. It's my pleasure to bring in Dr. Michael Osterholm. Dr. Osterholm is the director of the Center for Infectious Disease Research and Policy. In November 2020, Dr. Osterholm was appointed to President-elect Joe Biden's 13-member transition COVID-19 advisory board. From June 2018 through May 2019, he served as a science envoy for health security on behalf of the U.S. Department of State. Dr. Osterholm, can you talk about the lessons learned from the COVID-19 pandemic and the future of the pandemic in the U.S. and abroad?
Well, first of all, thank you very much for having me, Bobbi. I appreciate the opportunity to be with you, and it was somewhat daunting to follow the two really outstanding presentations from Tim and Jennifer, so thank you for allowing me that opportunity too. Let me start out, first of all, with my disclosures, and it's an important one. I probably know less about this virus and the actual pandemic today than I did 6 months ago. So you can take whatever I have to tell you today in that light, and the fact that we are learning so much so quickly. The second thing is that every morning when I wake up, at this point, I go reach over to my nightstand and take my crystal ball and work to scrape the 5 inches of mud off of it every morning to try to give a better sense. So you can take my answer about where this pandemic is going there. First of all, let me just start out by saying we are in uncharted territories. I've spent the better part of my career studying influenza pandemics, and Jennifer did a nice job of laying those out. And in fact, in my 2017 book, Deadliest Enemies, Our War Against Killer Germs, I laid out quite extensively what a pandemic might look like if it were an influenza pandemic. And whilst many of the issues are still hanging true, there are some real exceptions to what the situation is. Let me start out with the very first note. This pandemic is a long ways from being done. It's a long ways from being done. And that is not only on a global basis, but even on a national level. Today, we still have 65 million Americans who could be vaccinated per our current recommendations that are not vaccinated. And we have large pockets throughout the United States of people not vaccinated that basically make up the human wood for which this coronavirus forest fire will burn in future surges. These surges, while often thought to be, well, exhausting all those who are potentially at risk, let me just point out around the world, we've been following this closely. In Iran, after the second major surge, everyone concluded they had now hit this concept of herd immunity because of the number of people who had been infected and now immune. And then after the third surge hit, they said the same thing. And then after the fourth surge hit, they said the same thing. And then when the fifth surge hit this summer, which was the worst of the 5 surges they've had, people don't say it anymore because we don't really understand for certain, in fact, how many people have actually been infected who then are susceptible to getting infected again. In some recent studies, we've seen as high as 25 to 30% of people having a reinfection with COVID-19 in many of these areas. So vaccine becomes a very, very important issue. And I think Tim did a great job of laying that out. And he hit on a very important point. I agree completely the unique and amazing nature of getting these vaccines done. And one of the questions that we're still struggling with is, what does waning immunity mean? And with influenza, we basically developed a type of immunity to the influenza virus that was causing the pandemic and eventually became a seasonal flu virus within 2 to 3 years. We don't know what's going to happen here. We have no data yet to support that this virus is acting as a seasonal virus yet, even though the media wants to say that. If you look, in fact, here we are now coming down in cases in Minnesota and the northern states as it's beginning to get colder, not as it was that very warm fall that we had. I could go through a laundry list of issues. Earlier this summer, the 2 hottest locations in the world for cases were India, Nepal, and Pakistan, and at the same time, Argentina, Paraguay, and Uruguay. And the one thing they both had in common, they were at 30 degrees latitude. The difference when one was north and one was south. And so the point being is that we're still learning a lot about this virus and how it's different than influenza, which by now we would be expecting to start to become part of seasonal flu, just like the 2009 H1N1 pandemic did by the second winter. We don't know that's going to happen here at all. And one of the other challenges we have is not only are we not here in this country yet at a place where we can say we won't have more surges like we've just had, but globally, we are still in major shortfall in terms of vaccine matching up with the populations. Less than 3% of the continent of Africa has been vaccinated to date. Many other parts of the world have huge pockets of under-vaccinated people, far beyond even what we see here in the United States. Now, the challenge we have with that is, one, of course, they will contribute to the ongoing occurrence of cases. And by the way, on an international level, we see this cycling now that is now in its 5th cycle of cases bottoming out about 2.5 million cases per week. And then within 2 months, it's back up to 5.5 million cases per week, and then it comes back down again. And the world has been a combination of all the activity going on. Right now, the hottest place in the world is Russia. The Eastern European countries are close behind, and they are now far exceeding even the highest numbers we'd seen here in the United States. Just in the past week, we've now started to see Western Europe open up again. Meanwhile, South America and Africa seem to be very quiet. Well, that will be very different in 3 months, trust me. And we'll just see this in and out, up and down, and that's part of what this pandemic is really all about. But one of the other issues that comes up here with this is this concept of either not being protected or waning immunity, where the virus actually in its propagation in any one case creates a thing called a variant. A variant is a mutated virus that just every time that the virus has a throw at the genetic roulette table, something can happen. And early on in the pandemic, we thought variants were interesting. They were some way for us to follow the activity of the virus, but didn't ascribe any real purpose or impact of these variants. Then much towards the late fall last year, we recognized with two variants in Africa and South America, the beta and gamma variants, as well as the alpha variant that emerged in the UK, where now we could see that there were factors that were very important. Number one, they may be more infectious than other virus strains. Two, they may be causing more serious illness than other virus strains. And finally, the third bucket is they may actually evade the immune protection from either the vaccine or from the immunity as a result of infection. And this has been a grave concern as to what this means. Well, along this past summer in India, we saw the Delta variant emerge. And Delta, which was actually built, you might say, upon the Alpha virus that occurred in the UK, where that virus was 2 to 4 times more infectious than previous strains, Delta is now 2 to 4 times more infectious than the Alpha strain. And thus you've seen what's happened around the world with these Delta surges, which of course we just experienced here in the United States. And one of the challenges we have is we don't know what these variants are going to be like in the future. We're already following another variant right now, Delta AY 4.2. It has additional mutations in the regular Delta. There is some potential evidence that this may be more infectious than other Delta strains, and it may cause more severe illness. Again, we don't know what's coming down the pike. Remember, just a year ago right now, we didn't even realize variants were that important. And so one of the issues around this pandemic is going to be, what will the variants do? What role might they play in terms of vaccines? What role might they play in terms of natural infection and just the ongoing transmission? So that's one concern that we have. So in terms of vaccinating the world right now, we have an obligation, not only from a humanitarian standpoint, to do that as much as we can, as quickly as we can, but also from the standpoint of strategically protecting our vaccines that we currently have. And that's going to be a very important point. So waning immunity, I can't also say enough about that. I think, as Tim pointed out, with our current vaccines, there's a real concern. Will we need a booster in 6 to 8 months? Again, if we do, can we really duplicate that kind of model around the world, where every 6 to 8 months we might need a booster dose for the world? It isn't going to happen. So what does that mean? So this, when I talk about the end game of this pandemic, is far from over. And all I can say is that we are now coming back to a time in this country where people are feeling what I call the June feeling. Last May, I was not very popular when I said I thought some of the darkest days of the pandemic were still ahead of us, when cases were dropping precipitously and vaccine was flowing like water. And yet look what happened this summer. It's a very sobering thought to think about the fact when this Delta surge started in late June and early July, we had a country that had ample vaccine to, in fact, vaccinate the entire country. Since that time, over 70,000 people have died from COVID just since June, at a time when we could have prevented most, if not all of them. And so we still have challenges ahead that way, and that's going to continue on a global basis. In terms of just two factors I want to lay out, what really were surprises, or at least people should have considered. One, I think people are now just beginning to understand. I detailed this extensively in my 2017 book, Deadliest Enemies, that the supply chains were eventually going to collapse on a global basis, and that we're going to see major challenges with that because of what the virus would do in plants in Asia, what it would do to the shipping capability, what it would do to trucking. And as you now know, we're beginning to see these major shortages. And some of them, while they're inconvenient, others are critical. Right now, we're beginning to see a rapidly mounting drug shortage issue because, in fact, so many of the critical life-saving drugs we use today are generic and they're made in China and India, where we're now seeing the shipping challenges of major importance. We're seeing it in new cars. Why? Computer chips. Where do computer chips come from? Asia. What's happening again is the supply chains are going down. And I could go down the laundry list of issues. They're going to continue to be a major problem. And so that, I think, people hadn't appreciated is the economic impact this would ultimately have. The final piece is just what this has done to divide our country, and for that matter, countries around the world. I had a historian of some note share with me a few weeks ago, that over all the years of his work in the Civil War history, he had never understood until now what it must have felt like for fathers and mothers watching half their sons go fight for the North and half for the South. This virus has split families. This virus has split friends. This virus has split colleagues in terms of different groups. You see that today. Imagine healthcare workers who just a year ago were feted as heroes today are being attacked, ridiculed, and sued because they won't provide a drug that has been proven not to be effective and potentially dangerous, ivermectin, in the mix of all the treatment regimens that we're trying to use today to save these patients. This is, I think, a situation that reflects our body politic, and it has surely created a challenge that none of us really ever anticipated in a way that says, what can public health do or not do? And this is only going to continue. I don't see how we get out of this yet. We are going to have to somehow. But the bottom line message is right now, this country is as torn apart as it's ever been. And every day, the COVID issue just gets to be more and more of a confounder in that situation. So for me, any future pandemic is also going to have to understand what is it going to do to the body politic, to the social, political, and economic implications of a community. And I think this one has demonstrated what a pandemic does besides actually kill people. It also basically impacts on the very country we are. So with that, I'll leave it at that and know that that's not necessarily the best note to leave it on, but it's the honest note. It's where we're at right now. And I think that this really causes us to take a step back and ask ourselves, who are we, what are we doing, and what is this virus doing to us? So thank you very much.
Well, thank you, Dr. Osterholm. Those are very sobering yet very provocative insights. And with that, we'll move on to the questions submitted by our attendees. And actually, while you're submitting questions, I'll remind you that this will be posted on the YouTube channel for the Office of Academic Clinical Affairs tomorrow, and we will do our best to answer every question that comes in, so that the ones that we don't get to tonight, we'll try to have answers available, over some relatively short period of time. Let's see. Just looking here. Tim, there's one question here about the reason why mRNA technology wasn't used earlier in clinical trials with other respiratory diseases, or other diseases for that matter, I think. Can you comment on that?
Well, what I do know is that the mRNA vaccine approach was used in the study of cancer for many years. And I know that there had been some thoughts about using it in influenza and other respiratory viruses. But the fact is it wasn't until COVID came along when that became the approach. I can also tell you that there are clinical trials starting today, now, using mRNA vaccine technology for things like HIV, for example. So I think it's really opened the door to a new approach to vaccine development for some infections that have been historically incredibly difficult to make vaccines for.
Thank you. Jennifer, here's a question for you. How did the cases of influenza in the pandemic of 1918 finally subside? How was the epidemic or pandemic eradicated?
So I think that Dr. Osterholm actually answered this, that eventually, and he can correct me on this one, but eventually there is a higher level of immunity and the virus mutates, isn't finding active hosts in the same way, and ultimately becomes the seasonal flu. But certainly historians and scientists alike also think that the question about how long it lasted and the number of waves, so to speak, is more complex and longer than the sort of 1918, 1919 three primary wave story that we've learned.
Can I just add to that, Bobbi? I think, thank you, Jennifer. You actually were right on target with that. This is one of those humbling moments. Let me just take us back to 2009. H1N1 emerged as a new pandemic strain from Mexico in February and March of 2009. It peaked here in North America, as it did around the world, in late April, early May. and case numbers went up and the first wave came back down. There was no mitigation, no closing anything, no masking, no vaccines, no nothing. It just literally disappeared. Through the summer, we saw very little activity of any kind of respiratory viruses. And then all of a sudden in late August, it took off again in North America, peaking out literally in the end of September at a very high level, and then dropped precipitously just before a vaccine arrived in late October. Again, no mitigation, no distancing, no masking, no anything. The virus did what it did. Then we went into the fall, winter of 2009-10, and there, which we would normally expect to see other flu viruses, the only thing present was H1N1. The two influenza B strains and H3N2 never showed up at all. On top of that, the other respiratory pathogens, respiratory syncytial virus, RSV, any number of other respiratory pathogens were gone all of 2009-10. Never saw them. Why this interaction was occurring between the pandemic viruses, why it went up and came down without intervention is unclear. And in fact, we're seeing the same thing with this coronavirus. If you look last winter, we saw no flu activity. We saw no of the respiratory pathogens typically seen. And then all of a sudden this summer, we saw RSV, which would normally show up only in the winter months. And people said, well, it's because of mitigation was let up. We stopped doing this and that. Well, we have at least 9 countries that never did any mitigation for COVID-19 that saw the very same thing during the summer that we saw. Now, why is that happening? We don't know. That's why when people ask me what's going to happen with flu this winter relative to the COVID pandemic, I said, I know certainly what it's going to do. It's going to be somewhere between non-existent to a major outbreak. I just don't know which side it's going to lean towards. And I think that that's the challenge we have right now. There's something going on with these viruses interacting with each other and in populations that we cannot explain. And that, I think, is the humbling part. So in 1918, the same thing happened. Basically, the virus went up and down, regardless of what humans did, and then eventually just curved itself into the seasonal flu virus. But this is one of the humbling parts of this entire situation right now, trying to understand this very piece.
Thanks, Mike and Jennifer. Tim, what are your thoughts on getting a booster vaccine that is different than the initial choice?
Yeah, that seems confusing. If it's the RNA vaccines, they're very similar. I think, and Mike, you could probably help out. I think some of these recommendations are based on access and availability. Also, at least some of the questions I've had are about side effects for one vaccine, not wanting to get that. Could they get the other one? In particular, if you got the Moderna, could you get the Johnson & Johnson? But I do think there's some limited data to suggest that that you will get a boosted response if you so-called mix and match. Mike, do you know?
Yeah. No, I think, you hit it very well. And I think one of the things you said earlier tonight, Tim, was really important, is that as much as we fast forwarded these vaccines, and we did, there were 2 buckets of issues. One was on safety, and one was on how to make them work best. Dose spacing, how many doses, etc. We answered the safety question. There have been hundreds of millions of people vaccinated now, and we really have a good answer on the safety profile. So therefore, we can keep moving forward with these vaccines, but we're still learning how to space them. How many doses? What do you need? And I agree 100% with Tim's point. I've said for months, this is not a booster dose. This is the 3rd dose of a 3-dose series for mRNA, and it's a 2-dose for the J&J vaccine, and should be seen as that. I think that's very important. One of the things I think we're going to be challenged by, and I too get a lot of these questions every day, is the mix and match study that was done, that was presented at the FDA last week, included only 458 individuals. Now imagine we had 9 different cells to fill, meaning you had 3 vaccines by 3 vaccines. So you had to look at A and A, or A and B, or A and C, or C and A, and all the orders. And so we don't have that much data, and we don't know what the cohort of protection is yet. We don't know immunologically what the antibody is or level, or the T cells. Ironically, if you look at the early studies of these vaccines, in fact, we saw protection develop in the populations before we could even measure antibody. So there must have been something from a cellular standpoint or something going on that actually afforded protection that we don't know. And it's even interesting right now, I think we're going to see over time, the vaccine, I think, that's going to ultimately end up winning the race is J&J, which many people say, how can you say that? And it's because if you look at the mRNA vaccines, Moderna is a little less than Pfizer, But there's this waning immunity that's very pronounced. And we don't know what that means, but we surely see the breakthrough cases. With J&J, you didn't get a high protection with that first dose. It was in the 70-some%. But what happened over the 6 months is that 78% went to 84%. It just kept getting better and better and better the whole 6 months. And now with the second dose of J&J, you actually get into the mid-90s for protection against infection, severe illness, and hospitalization. And it may end up being that J&J is going to be the vaccine that is enduring, that you get longer term protection with. So the bottom line is stay tuned. I tell people right now, if you got a Pfizer, if you got a Moderna, if you get a J&J, get the same one. But we'll learn this. And as Tim pointed out, we're going to learn a lot over the next year or two, and just stay tuned as we get better at this.
So here's a question for all of you. Does the public confusion and skepticism that has confounded efforts to vaccinate our population have roots in an insufficient education system in our country? Specifically, the scientific process seems to be poorly understood by many. Are there things that we need to do that are different going forward so that we can help educate people better and protect ourselves more in the future?
Well, let me just start out by saying we don't know how to deal with disinformation. We don't know. I mean, imagine this. We've got vaccines that have gone through the most rigorous clinical trials, double-blind, placebo-controlled trials, the gold standard of testing the effectiveness of a medicine or a vaccine, whatever. The data are compelling. And yet we have data showing in similar studies, and the University of Minnesota was one of the first groups to do this in a very important study, show that ivermectin, this anti-parasitic drug, was not effective, and in fact potentially could get to be a toxic kind of situation. And yet we have people today that will not get a vaccination, but they absolutely must have ivermectin. How do you deal with that when, it's just information? And so I think the socialization of information on the internet and the disinformation that's out there today has made a lot of people, they have their own set of facts. And this is something we've never dealt with before. This is very different than vaccine hesitancy. This is really a whole new order of science that I think that we're trying to deal with right now. And many of us don't have answers for what to do about it, other than we know it's a real challenge.
I would agree with everything Mike said. It's interesting in the era of social media, that's something that's brand new and anybody gets to say anything and it gets to be broadcast widely. And that's a new factor. And so it's really challenging for people to sort out what's real and what is misinformation. And I think we're going to have to deal with that.
Yeah.
In order to be able to effectively teach people or educate people as to what the scientific process is and what the data mean.
So, Jennifer, I'm sorry.
Well, I would totally agree. And I would just add that I think people always want certainty. And I think we increasingly want a soundbite kind of certainty as opposed to a nuanced informational certainty. The part that worries me is healthcare workers who presumably have had a good science education turning down a vaccine.
Any thoughts on that, Mike?
No, I think that's absolutely true. I will say that if you look today, 99% of physicians in this country are now vaccinated. So, I mean, and nurses, it's a very high percentage also. I think where we see more active anti-vaccine activity in healthcare workers, it tends to be in the technicians and technologist type people who may not have had the same level of education about this. But it is still a challenge. I worry desperately about long-term care right now. We have employed over the course of the past decades people at virtually minimum wage for a damn tough job. And what it's attracted is a group of people from a socioeconomic standpoint, from an education standpoint, that are not as likely to take the information from science and consider it to be valid information. And so now you're seeing long-term care facilities that didn't have enough employees to begin with. And now they're mandated to get vaccinations and they won't, and they're walking off the job. And this is a healthcare crisis, I think. Right here in Minnesota, the National Guard have now been trained to come into certain nursing homes and help out just because of the lack of people. So the healthcare area is surely under challenge already for not having enough people to do the jobs that we need to. As you know, the shortages we're seeing around the country right now often have less to do with rooms and equipment, and more often how many staff people are available to provide the care. And so we can't afford to lose any healthcare workers, but still that is a challenge because we are losing some because of the vaccine mandate.
So Tim, here's a question for you. Will it be straightforward to modify mRNA vaccines in the future to address mutated viruses?
Yes.
Okay.
Yep.
It is straightforward. I mean, you know, if we know the sequence, if we know the sequence of the virus, we know where the mutation has occurred, which we can find out relatively straightforward, then you can make that vaccine to that sequence. And it's a pretty straightforward process. Remember, I mean, many people probably don't know this, but that sequence of the original strain of COVID was put online sometime in mid-January of 2020. And it wasn't 5 to 7 days later when Moderna and Pfizer had already started synthesizing their RNA vaccines. It was an incredibly short period of time. So the answer is yes.
So that should be good news.
I think so.
Mm-hmm.
So here's a question, and this can go to any of you. There are people who are trying to become infected with COVID thinking that it works like chickenpox. Can any of you comment on whether that's a good idea or why it isn't a good idea?
No, 1,000 times no. You know, we don't know in every instance who's going to have a severe outcome or die. I know far too many people, even younger individuals, who don't have a designated risk factor for increased illness, and yet we see these people seriously ill. If you look at what's happened in this most recent surge, we've had a major increase in 20, 30, 40, and 50-year-olds who have now developed severe COVID and died. And so, you know, don't risk it. This is not as simple as just saying, you know, if I get a little bit more severe illness or less mild illness. This is like trying to run the railroad crossing when the train comes by just for the hell of it. You know, don't do it. And so I encourage people. We know people who have tried to do this, and we know of people who have had fatal outcomes just trying to do this very thing.
The other thing I would add to that is that there is this condition called long COVID.
Yeah.
It affects about 40% of people who get infected, even asymptomatically. It's brain fog. It's people losing their memory. It's persistent and permanent respiratory problems. And like I said, it's 40% of people that get COVID have this long COVID syndrome. And then finally, fine, you go get infected, but you're going to infect other people. And it might be that it's a Colin Powell situation where they don't have a good immune system. The vaccine didn't take, and now they're getting COVID and dying as a result of that. I think that's really irresponsible.
Yep.
No, and no.
Well, I think we've reached the end of our time. I'd like to thank the panelists for all of your time. This was fascinating. Whether we're thinking about the history or the future, your insights were just terrific. We'd also like to thank all of you, the participants, and your questions and your engagement and joining with us today. We'll see you again next week for the second mini medical school session on health and wellness during a pandemic. That'll be at the same time next Monday. We have an amazing group of experts that will discuss the impact of COVID-19 on other diseases. We really hope to see you there and have a nice evening.